Thank you, Helen. That was a really fantastic talk, and congratulations to everybody, and especially, you and Eleanor for leading on this from a national scale. We've got quite a few questions in the chat, and just dot about a bit. But shall we start with, do you have any specific formula for ICRs in pregnancy?
Just in general, what I tend to do is if I see that the algorithm's having to really boost the basal insulin after a meal, I'm strengthening the ratios as much as you can. I mean, basically, the management of type 1 in pregnancy is about driving to the brink of hypoglycemia without being hypo. So it's pushing as far as tight as you can, as safely as possible. And I see there's one question in the chat about whether hypoglycemia can cause problems for the babies and mums. And to the best of our knowledge, it does not cause problems for the babies, but of course it can cause real problems for mums. So I'm not in any way blasé about hypoglycemia prevention, but I think in pregnancy we have to push as tight as we can, as quickly as we can. And I should add that we are developing a Daphne tool, because I think there's been the Daphne closed loop module outside of pregnancy has been incredibly successful. So we have one that will soon be available that will be around using pregnancy specific hyper closed loop, mainly to support teams and staff who have not had access to have that kind of training for use in pregnancy.
Great, thank you. So Adele Kennedy would like to ask you a question. Over to you, Adele.
Hello, can you hear me okay?
Yes, yes.
Yeah, lovely. Helen, as always, I just look forward to your talks. They're excellent and motivating. My only problem is here in Northern Ireland, because I think must be because of the circuit study and the crystal study, I was able to say the CAM APS system is the one that is licensed in pregnancy. Now I'm having young girls coming in, and they've been told by the reps and the DSNs that the Tandem T Control IQ and the Medtronic 780G are safe and effective to be used in pregnancy. And despite I just feel as if I'm fighting a losing battle. Unfortunately, in Northern Ireland, we haven't any funding to change over. Are you seeing more of the girls coming in with Tandem in England, or is it just a case they're all changed to CAM APS, so there's not a problem? Thank you.
I mean, I think we've been incredibly lucky to work really closely with our colleagues in maternity, who before we had this data actually did believe us that, potentially continuing the other systems may cause problems. So yeah, it is absolutely true to say that the Crystal study and the Circuit study, of which I'm a co-author, have both of those systems are now licensed for use in pregnancy. But in the UK's healthcare setting in England, it's not just enough to have a license, because people think a license means it's effective, but it isn't. A license just means you've done a study. The Medtronic study showed no improvement other than 24 minutes overnight, which isn't enough of an improvement to do anything. The Circuit study did show an improvement, but I think the important difference is that the Tandem Control IQ, it's not a learning algorithm. It doesn't adapt. And if you look at one of the really surprising things in that study is the control group didn't really improve. So I think that the criteria of a system that should be effective in pregnancy, it has to fulfill all of those. It should have a license. It should have at least a 5 percentage point improvement. Now, the Medtronic system doesn't have that. The Tandem, you could argue, should have, can maybe do that. I'm a little bit cautious because I think it showed an improvement because the control group didn't do very well. So I don't believe it showed such a massive improvement. But it should also have a lower glucose target, and the other systems don't. So in the UK, if either the Tandem, the Omnipod, if any of the other systems kind of adapt their algorithms and can show those benefits, then they should for sure be used. But out with of that data, which isn't apparent at the moment, continuing those other systems is associated with poorer maternal glucose, higher rates of preterm births, higher rates of large babies, and potentially higher rates of perinatal death. So actually women are better using basic MDI than continuing on the other systems at this point in time.
Thank you. I knew that question had come up and it beautifully answered, so thank you. After pregnancy, Do you have any data that women continue breastfeeding more often than, you know, those on pens, for instance?
Yeah, no, really nice question. It's one of the things NICE have looked at in their draft consultation. And I think, so we don't have enough statistical data to say anything very scientific because unfortunately the breastfeeding rates, you know, are still pretty low. But yeah, you know, what we are able to say is that the women who did continue breastfeeding had higher time in range, but I'm cautious to make too much of that because, of course, it's a certain sort of person who's more motivated to continue breastfeeding. And deep down, if I'm being honest, I think women's choices around infant feeding are much more to do with other societal and family issues rather than the glucose levels. There are women who choose to breastfeed. There might be an occasional woman who is unable to because of diabetes, but I'm not personally persuaded. I think that, yeah, we're seeing lovely, safe glycemia in women, regardless of how they choose to feed the babies. We are seeing that it's safe in breastfeeding. There's no more hypoglycemia. There's maybe some maternal glucose benefits, but there's so many other benefits to breastfeeding that I think that's relatively small.
Great, thank you. And could you just clarify at what threshold you would say treat for hypo in pregnancy?
Oh yeah, no, really nice, good questions.
And then advice around driving.
So this has come up quite a bit recently, actually, and I think you know there are differences in some of the sensors, aren't there, in the low glucose range. We all kind of know this in our clinical practice. So really, I'm saying to women, you know, I'm asking, begging in every clinic, you know, please still carry a glucose meter with you and do check if you're symptomatic of a hypo. But I know in reality it's not always happening. So we are saying a capillary glucose level of less than 3.5. I'm saying, of course, watch out for your symptoms. I think the big difference we see in the management of hypoglycemia on the CAM-APS system is that you can get away with having just microcarbs. So I think sensors are allowing women to detect that the glucose rate of fall or the glucose is dropping, and they're able to manage it with a smaller fast-acting carbohydrate that, you know, might be 5-7 grams rather than we might have told them 15 grams, wait 15 minutes and then treat again. Now we're seeing that often the microcarb can be enough and adequate for most. And part of me thinks that might be the reason why women gained less weight in pregnancy, because they were not having to overtreat their hypos. In relation to driving, for me, it's the same kind of as exercise guidance, or the same as, you know, when you're in hospital having a baby. So at least 5 before you drive. I'm personally very comfortable because it's very easy to overshoot with insulin. I'm very comfortable having women sort of running around about keeping glucose levels, ideally between 5 and 6, but close to 6 is also fine. So there's a margin of safety.
Great, thank you. And after pregnancy, do you try to keep people on the same pregnancy specific? Because not all pregnancies are bad, are they?
We've not been able to get them off it. We've had, you know, I've certainly had a few of those younger age women who come in on a patch system who are more reluctant to change. And then we say to them, you know, if you're willing to change, just try it for, you know, try it out for 4 weeks, 6 weeks, try it out for your pregnancy. And if you don't like it, go back to your other system. I've had 1 or 2 who've come off, but it's a very, very small minority.
And to answer the last comment around Hardy saying that, you know, how do you persuade people? I guess some of that is actually, you know, using the data that you presented today, isn't it?
Yeah. So I think I had faith in it, of course, because I've been involved in working in it, but I think it is really nice for us to know, you know, one of the things I think with some of the other systems is you'll get an occasional patient who's very motivated in an occasional center with an occasional clinician who can tweak, you know, if someone's good enough to do the maths with one of the other systems and they can make all the adjustments to make up for the algorithm not adjusting, then you'll get an occasional woman who can do okay on another system, but there's no other system that's actually safe and effective for nationwide implementation. And for the more reluctant women, most women are motivated by wanting to do the best for their babies, and for the more reluctant ones, the difference in weight gain is often a deal breaker.
Yeah, I've certainly used that myself. Can I ask Julie's asked, do you have a target for CV? I mean, the target is more around time and range and avoiding hypos, I guess, but
At the top, my target. So the things I look at actually is the time in range and the mean glucose. So they're the two things to me that really matter. And I only tend to be that look much at the CV if there's problematic hypoglycemia.
great, thank you. Liesl.
There's lots of questions coming in from everyone, which is great. But can I just say, Helen, that I'm really quite emotional looking at the results that you've achieved. When I cast my
Not
mind
me
back,
personally.
no, I don't. But through the support and the education and the policy, everything, being able to implement what you have implemented for these women during their pregnancies, before and after. When I cast my mind back to running antenatal clinics in 1998, 99, when we didn't have carb counting, we just had finger pricking. People weren't using ratios. It was just change a dose by this or that. I mean, it's night and day to what it was before. And I have to say, I'm so excited. Almost, it almost feels like the next best thing to a cure. So thank you so much for presenting this today, because it is just, it's phenomenal. So I'll let everyone else ask their questions. I just wanted to say thank you. It is phenomenal, and these women are achieving enormous things. And thank you.
And, I honestly, genuinely think the best is yet to come, because I think as more women enter pregnancy, like I'm almost retired from type 1 pregnancy care, not totally. And the women with type 2 are keeping me more than busy enough, the early onset type 2s. But I think it's a real treat now to be not to have to kind of safeguard all the type 1s, to actually be able to say that, we can spread them out across the clinic and everyone gets to kind of experience, get some hands-on experience, isn't it, of supporting these women. And we're having to have, our clinics now for type 1, it's much more often that we can see women on a 4-weekly basis than ever before.
Wow.
Great.
Amazing. Thank you.
Thank you, Liesl. So Kieran, who's just joined our central team, I don't know if you can see that, Helen, 1317, but he had lots of questions for you. So the first one is, what about those that can't really carb count? Do you use small, medium, large?
Yeah. I know I'm at the Daphne meeting and I mentioned that's not supposed to be the answer, but there's not that many. So what we have tended to do, and we did this in the study and we do it in real life. So of course it's going to work better. Women are going to do much, much better if they're able to be accurate around their carb counting. There's no doubt at all about that. But actually, most of us eat about 10 to 20 things more commonly. And if you can work out the average amount of carb intake at breakfast, lunch, and dinner, and then set that up on the small, medium, and large meal function, the algorithm will give a little bit of forgiveness around the accuracy of the carb estimation. So yeah, carb count ideally if you can, but if you're struggling with health literacy or numeracy, you get a wee bit more forgiveness. The other question actually I'm being asked is, what about the fully hybrid closed loop, or the so-called Liberty function that's coming soon? And just maybe worth saying, I don't think that should be a standard use in pregnancy. There might be a very occasional low levels of literacy, numeracy patient that, maybe there'll be a role for, but there's no data in pregnancy.
Okay.
And the other thing that is coming actually is what I've been calling the pregnancy button. But Roman corrects me and says we should call it the pregnancy profile, because the pregnancy button, women might think then they can get pregnant when they press the button. But we're going to launch the pregnancy profile, which will mean not only we'll be able to have the HbA1c data from the audit, but we'll have the hypoglycemia data, the time in range, the mean glucose, the CV. So many of those questions people are asking, we will be able to get data to answer those in the future.
Okay.
And any insulin, it doesn't matter what insulin you use, NovoRapid, Fiasp, or anything of similar, that they'll all come out the same.
Great. And then do you know anything about CAM-APS moving into a patch pump?
Oh, that would be the holy grail, isn't it? Everyone would love it if there was a patch pump. I do think that that's something, I know it's something Roman and the team are working on. I still think we need to just have a wee bit of heightened suspicions and level of caution around the risk of DKA in pregnancy. So for me, I'd have to be absolutely assured that they're not going to knock it off and very quickly go into DKA because of the increased fetal risks. So yeah, maybe in the future, but no data yet.
And the second part of that was a pump that could allow higher amounts of insulin. We're always going to be limited
yeah,
somewhat with that, aren't we?
Yeah, I get asked that actually quite a lot. You know, we had women with BMIs of up to 49 and really some women using quite high doses during the studies. Where I'm not seeing the need to increase the, I really firmly believe if you can get on top of the insulin resistance early in the second trimester, it's not such a problem in the third. So we're not seeing such huge increases. So I've not had to do anything. I've not had to worry about that personally. I know, having been in Sweden a couple of weeks ago, that colleagues in Europe sometimes are using some basal insulin alongside the CAM-APS. I personally am not doing that, but I hear in selected anecdotal cases that it can be an option.
Right.
CGM. But now we've gone from 23% of so we've gone from 23% of people of women reaching the pregnancy A1C target to 53%. You know, that's a stonking 30 percentage point increase, more than doubling the women who are able to achieve the really tight targets we're looking for. And you can see here much more clearly the difference between women who continued on another form of hybrid closed loop, around about a third of them, just over 33, 35%. And of course, women using standard insulin, you know, were also doing quite well. So this data is showing you that the other hybrid closed loop systems did not perform any better than standard insulin with the CGM across the course, across the entire pregnancy. And then you see that very clearly for the really tight glucose targets, less than 43. And you see the same kind of pattern for women with an A1C of 43 to 48. And then, of course, as you might expect, you're seeing more women using the other hybrid closed loop systems in that slightly higher 49 to 58 category. So this is kind of what we expected. And it was certainly the signal that was coming from some of the real world studies, but actually to have it shown nationally in a nationally representative population, that for the first time ever, we can really be able to achieve in more than half of the women the very tight targets we're looking for pregnancy is, a hugely exciting kind of step. And I think, as Jackie mentioned earlier, you know, Bob very much wanted the pregnancy audit to be used to drive improvements. And we can categorically say the data from the audit have really, you know, informed the rollout of CGM, and now they've informed the rollout of the pregnancy-specific hybrid closed loop. And of course, the benefits that will come from that massive 30 percentage point more women reaching target, particularly as time goes on, are going to be really important for mums and for babies. And then this is just showing it to you in another way. So showing you that the median HbA1c in the pregnancy-specific hybrid closed loop users was down to 42, and then really no difference between the other hybrid closed loop versus MDI or pump alone. Does any of that matter? Well, of course, nothing matters in pregnancy if it doesn't have some impact on the obstetric and the neonatal outcomes. So what we saw was a very clinically and statistically significant reduction in preterm births in the pregnancy-specific hybrid closed loop users, and rates of preterm births in the standard or other hybrid closed loop users no better than other standard insulin types. And again, changes that are clinically and statistically really important. And actually, one of the things, or certainly what I've observed in my own antenatal clinic, is that we're seeing women entering pregnancy with tighter A1Cs, maintaining more optimal glucose levels the whole way through. We're starting to see this shift in the birth gestation towards an extra week. So you can see here that there were specifically fewer preterm births in that 34 to 36 week window in the pregnancy-specific hybrid closed loop users, with many of them making it to 37 and 38 weeks. And again, that's quite significant, and significantly more women delivering at that slightly later gestational age, which of course is, you know, likely to have important longer term benefits for their infants. And And then really these are the data we predicted from some of the smaller population studies. We had a sense of them from the randomized trials, but actually to see that for the first time in the UK, having presided over this input data for years and years and years with nothing changing, actually we now have across the entire UK the lowest LGA rate I think we've ever seen in our type 1 population, so down to 37%, and higher, more larger babies, so 54% in the women who continued on the other hybrid closed loop systems, 47% in women who continued with a pump and an MDI. So I know some of you have been tired listening to me saying for the last few years that I didn't think there was a benefit in continuing the other hybrid closed loop systems. And now we're saying, well, there's definitely no benefit. And actually, from the baby's point of view, those mums could be better off with using MDI or pump therapy without continuing on a standard or a non-pregnancy optimized system. And this is just showing you again it's a little bit like the gestational age, just a much more normal distribution of the infant birth weights in the mums who continued, who started on pregnancy-specific hybrid closed loop, and fewer of those appropriate for gestational age babies, with women on who used other systems, and then again the women with MDI or pumps doing a little bit better, and importantly, no additional small for gestational age babies. When it came to the neonatal care unit admissions, actually, firstly, this was set at 54% for many years, and it's now down to about 27%. And actually, it's kind of surprisingly no huge difference between the systems, but I think that's because of the really small, only the 65, small numbers of women who are on the other systems. So I think we probably need more data to say anything too concrete about that. And then finally, this is probably this really is the data that we modeled and that informed the Saving Babies' Lives suggestion that women should be swapped, was we were able to project how many babies' lives would be saved if the ADAPT trial results were replicated. And actually this shows exactly that. So the numbers, yes, are small from any 1 year, but what we're beginning to see now is the lowest rates of perinatal deaths that we have ever seen in the type 1 population, and a sense that not surprisingly, it's maternal glucose that is driving that. And if you're improving the maternal glucose, you expect to see that improve. And we are actually seeing real benefits for mums and babies, not just in the milder complications of preterm births and LGA, but importantly also in the serious adverse outcomes of major anomaly, stillbirth or death. So take-home messages really is that and they're the same as before, but I can say them even with a little bit more certainty, that the use of the CAM-APS, what we're now calling pregnancy-specific hybrid closed loop system, really does improve the maternal glucose with a magnitude of effect that is much more prominent than with any of the other closed loop systems. The system works super quickly. It really does work within the first week, and I expect to see a 10% improvement in the first week of use. The benefits of hybrid closed loop use during pregnancy are system specific. I know that is very different to outside of pregnancy, but now we actually have some national health outcome data to say that actually is the case. And of course, the benefits extend to continuing to use it postnatally, and hopefully also improving glycemia coming into the next pregnancy. So I think that's it. And I've just remembered that we did do a health economic analysis based on pretty conservative data, and this was important for NICE, but this using the pregnancy-specific hybrid closed loop, it's not just clinically effective, it is also cost effective. And indeed, some of the benefits were more than what we had modeled. So this is modeled on just third trimester data, but actually, the more important thing really is getting so many women, even in the second trimester, to target HbA1c. And I think that's why we're seeing lower LGA, lower preterm births, and lower perinatal deaths. So